My name's Tom Hart and I'm Health Poverty Action's Country Director for Guatemala. The main health problems in Guatemala are around things like nutrition, where we have one of the highest chronic malnutrition rates in the world. Added to that are problems around sexual and reproductive health, for instance, maternal mortality rates. We also have a great deal of problem in affording people access to health services. That means that very often people will be reluctant to seek treatment and to seek health education with the Ministry of Health. We're now coming across other specific problems which are to do with a country which has become a middle income country, and those are to do with changes in diet leading to problems like diabetes, which is particularly prevalent in Guatemala. Health problems in Guatemala affect people's lives to an enormous extent. Where we don't have a social security system, that means that if someone falls ill, they lose their daily income, and that in turn means that the whole family is impacted by the way that one loss of salary, one loss of income for a day, for a week, or for a month has a tremendous effect upon the whole family. It's also the case that if, for instance, we have poor nutrition during a woman's pregnancy, say, then that will lead to low birth weight. It will lead in turn to a child with low developmental prospects. Very often, if a woman is malnourished during pregnancy and the first 2 years of the baby's life, then the development of the brain, for instance, will lead to cognitive problems later on, or at least a lack of cognitive development. That means that a health problem at a certain stage of a woman's life will have an impact on her child's life, which can never be corrected and is a problem for that child's entire life. People's lives in a country like Guatemala are determined by their levels of poverty, and that means, for instance, that one has to decide within the family how many children to send to school. One has to decide how many children to allow to develop in terms of their preparation, their life skills, their tools, and that in turn means that we have a cycle of poverty leading from one generation to another. Obviously, levels of education themselves have a direct impact upon health and health status later on. For instance, when we talk about women's maternal health, when we talk about sexual and reproductive health, there's a very clear correlation between the educational status of the woman and her sexual and reproductive health outcomes and her status throughout life. So it's a circle. Everything depends on poverty. Poverty will also determine what we call people's health-seeking behavior. That means that someone may or may not decide to seek medical attention or to go to hospital with a health problem according to whether or not they have the money to pay for transport to get to that area. If people weren't so poor in a country like Guatemala, then they would be much more participative, they would have ownership of the system of the state. By that I mean that currently in a place like ours, in rural indigenous areas of Guatemala, people feel that they are not the owners, they are not the people who can decide how their services are provided, whether that's health services, whether that's the accountability of local government, whether that's to do with any other aspect of public policy. And so if people weren't quite so poor, they would have much more engagement, they would have much more sense of ownership, and they themselves would be able to decide. It would mean that they were no longer passive recipients of state services, but they themselves, working as a group and working as a community, would be much more able to shape and to guide the public policies and would be able to hold duty bearers to account. That means things like demanding of the local mayor, demanding of the local health services that they perform their functions, that they fulfill the roles that the state and that the legal framework assigns to them, but which currently people, because of their poverty, feel they cannot demand, and they cannot demand accountability. Currently, Health Poverty Action in Guatemala is working on a number of different areas. One of the things that we're seriously concerned about at the moment is violence against women. This is something which has enormous health impact in people's lives. Obviously, there are physical consequences of physical and sexual abuse. But also we're talking about the social health of the community. We're talking about the cohesion of a community. In a place like Guatemala, for instance, there is tremendous impunity for violence against women. A recent study that we did in the project area in Guatemala showed that something like 80% of adult women have suffered some form of sexual, physical, verbal, psychological, or patrimonial abuse at some stage during their lives. Health Poverty Action is trying at the moment to take a holistic approach to the problem. That means that first of all we're trying to make women and men aware of the legal framework in Guatemala which exists against violence against women but which is currently not being implemented. But apart from raising awareness, we're also trying to raise the capacity of local actors, especially state actors, so that the police can respond to women's reports, so that the justice system can respond and follow up on cases, so that the health service, for instance, is trained on how to deal with survivors, so that teachers are able to introduce violence against women in the curriculum in the classroom. So we're trying to increase the demand for improved services, reduce the tolerance for violence against women, and at the same time improve the response for these new survivors and for these people who are beginning to talk more openly about the violence that they've experienced. We're also about to start, with the help of the Big Lottery Fund, a new project on culturally appropriate maternal health services. At the moment, for instance, most of the health service in Guatemala, although it is free for the users, isn't accessible to people within indigenous communities. And by that I mean, for instance, that most of the health workers, whether they're nurses, doctors, auxiliary nurses, community health educators even, don't speak the language of the community which they serve. And one can imagine trying to institute a health service in the UK, for instance, where the health professionals weren't addressing their patients in English. And so this is something that we're trying to work on with the support of BLF and work with the Ministry of Health to improve the quality of services, so that they also respond to the needs and the desires of people within the communities to have a service where they feel comfortable, where they feel welcomed, where they feel that there is a quality of service which responds to their needs. We're also working in Guatemala on issues such as nutrition, education and so on through our partners in networks. Health Poverty Action knows that we ourselves alone cannot do everything, and what we are very concerned with is to build institutional and organizational capacity within Guatemala and the rest of the countries in which we work. That means working with civil society organizations, community-based organizations, so that we're giving them the tools to work together to be able to monitor the quality of services. And this, as I say, in our case, includes nutrition, it includes education, it includes health, it includes all sorts of services where people learn how to organize, where people learn how to demand, where people learn how to hold their local office bearers and duty bearers to account, so that they begin to provide the services in the way that Guatemalan legislation obliges them to, but which up until now they have not been obliged to respond to.